And so let me start by introducing Lauren Wood. Lauren serves as a policy analyst for the National Governors Association Center for Best Practices. She focuses on public health issues, behavioral issues, substance use, mental health issues. She has had prior work with organizations such as the Pew Charitable Trust. She has a master's degree in policy and health promotion from the University of Arizona. And we're very pleased that she could join us today because, as you'll hear in a minute, one of the products that she worked on was a synthesis, a systematic review of the way Pdmps are being used in states across the country. The next panelist is Dr. Tim Westlake. Dr. Westlake is a full-time emergency room physician who lives and works near Milwaukee, Wisconsin. He's the immediate past chair of the Wisconsin Medical Examining Board. He has recently joined the Controlled Substance Board in his state, which is the oversight body for their enhanced Pdmp, and he helped guide the development of the reform of their prescription opioid strategy, and served on the executive design team for developing their state's enhanced Pdmp program. And last but certainly not least is Christine Hancock, who is a practicing family physician at a community health center in Washington State, the CMAR Community Health Center in Bellingham, Washington. She's the clinical director for their opioid initiatives across all of their clinic sites here in Washington. That includes their medication for opioid use disorder program and opioid prescribing for chronic pain. She completed her residency program at UCSF in Santa Rosa and left sunny California for the rain of Seattle and the Pacific Northwest. And we're just really pleased that she could join us here today as well. So Lauren, let me start with you. And I'm just trying to check. There you are. Okay. It always helps for me to see a face when I'm talking to someone. So thank you for joining us. Tell me a little bit more about your role at the National Governors Association, and did I say anything incorrectly in my introduction?
No, Michael, you did not. And thank you so much for having me on today. Before I kind of dive into my role, just to give you a bit of a background on NGA. So for those not familiar, NGA is the only bipartisan organization representing all governors from the 55 states and territories. And so within NGA, there are two sides of the House. We've got our Office of Government Relations representing the not sure what was happening there, sorry, representing states and the governors before the administration and Congress. And then we have the Center for Best Practices, which is where I sit, which is more of the think tank and kind of consultancy side of the shop, and supports states on policy issues relating to anything from health, homeland security, education, and just a number of other domains, all which serve to provide, again, states with best practices and promising practices. So in my role, I'm currently a health policy analyst within the Center for Best Practices. And for the purpose of today's discussion, my work largely focuses on substance use disorder, opioid use disorder, and public safety responses to both, with more of a budding focus on issues such as stimulant use and kind of behavioral and mental health at large. And as Michael noted before, prior to joining NGA, I was at Pew and served as a social worker and a grants manager at an FQHC in Colorado, working with the SUD, OUD, SMI, and homeless populations.
Fantastic. So Lauren, one of the reasons we wanted to hear your perspective on this, as I mentioned in my introduction, your organization released a report last summer, I believe August maybe, on how states were developing or enhancing or using developing their state's prescription drug monitoring program, Pdmp as it's known. What was the background of why was that report created? What was the purpose or intent of creating that report?
Yeah, absolutely. So the toolkit is titled State Strategies to Improve the Use of PDMPs to Address Opioid and Other SUDs. And it was actually spurred from a partnership between NGA and the Office of the National Coordinator. And really the goal of that project was to surface insights about best and promising practices for PDMPs by conducting an expert roundtable. And I saw from the chat that we have a few folks and states from that roundtable that are with us today. So glad to see you all. But with that roundtable, we really wanted to highlight state practices in PDMP policy and identify opportunities to improve access and ease of use of them in order to create the toolkit for governors and states based on that expert input. So the toolkit really speaks to those different approaches that states have taken to inform governor level considerations and help other state leaders identify opportunities to advance not only the functionality, but also the utilization of PDMPs as part of their broader data approaches to identifying trends, reducing SUD, and improving connections to care.
That's great. That's great. Thanks so much. And while we're mentioning that report, I'll just ask if someone on our team could maybe put a link to the report in the chat for the audience.
I'll do that right now, Mike.
Oh, thanks so much, Sharon. Really appreciate it. So in thinking about your findings in that report, what do you see as key innovations across states that you think were working well regarding especially opioid prescribing practices? Any thoughts about common themes or innovations that you thought were particularly helpful or interesting?
Yeah, absolutely. It's a great question. So in terms of some of those key innovations we garnered, and as you'll all see from the report, so there's 10 considerations that we put forward based on that expert feedback we received from the roundtable. And in reflecting on really some of the many kind of data challenges and sharing and privacy issues, in addition to just considerable variability in state approaches, I'll just quickly run through a few that we mentioned in the toolkit, with certainly the caveat that these examples are just kind of the tip of the iceberg with all of the great work that's going on among the states. So first we noticed that Nebraska has really been a leader in this space, as I believe they were the first to track all dispensed prescription drugs, and that's really improved their medication management, reduced medication errors that accounted for admissions or readmissions to hospitals, and it's also allowed for them to identify other early patterns or trends in dispensing or prescribing. And then, for example, in Massachusetts, they connected their data from EMS, hospital and bystander interventions, and analyzed those alongside their PDMP data. So state officials from there were able to capture, again, just a multitude of those data points to better inform their OUD and SUD policies. And according to the feedback we have received, those data linkages really allowed for the state to see reductions in overdose and improvements in provider education and more generally kind of in their SUD treatment services. And then just a few states away, we heard from Maryland in their predictive risk modeling tool. And I believe they started that in about 2014, but through that tool, they were able to identify about 40% of their overdose deaths as of 2016, while with the expansion of their clinical and other criminal justice factor data sets that they merged in, led to a more accurate kind of prediction of risk for overdose from, of course, what we know to be a very broad and diverse and susceptible population. So again, those are just some of a few highlights and kind of innovations that we saw within the states.
And can people read more about those innovations, more details in the report itself? And are there ways for people to connect with individuals in those states to learn more, or if they have questions?
Absolutely. So we don't name individuals that we spoke with, again, by name in the report, but all of that information is certainly linked in the report. And as you'll see through, for those that are viewing it now, in the consideration section, through the 10, we link out to each one so you don't have to continue to scroll. But certainly at NGA, we are more than happy if any of our participants on the line would want to speak with any of those states. We're happy to facilitate connections.
Great. That's helpful. Thank you, Lauren. That's really great. Well, Tim, let me turn to you, Dr. Westlake. Thank you so much. Really appreciate you joining us today and taking time out of your, what I'm sure must be an incredibly busy schedule. I'd like to turn back to your role and your current work in your state, and how does it relate to your state's PDMP? Can you give us a little better insight into that?
Sure. Thanks for inviting me to contribute. So I was on the medical examining board as the vice chairman for a while and ended up as the chairman. And one of the other things we did had some oversight over the Controlled Substance Board, which oversaw the prescription drug monitoring program. And when I started, the PDMP was this legacy software system. It literally took like 4 minutes to log on. And so when it became apparent that we were going to need to implement some reforms that included, mandating prescriber evaluation of the PDMP prior to prescribing, then it was apparent that we had to get a clinically useful tool. And so that was the key thing for me as a driver, as someone that was, worked in the emergency department every day. If you put a mandate in for physicians and health practitioners to do something, you really need to give them the tool that makes that the most optimal tool that it can be. And so that was the goal from the start for me, was to come up with a tool that would be useful and not just another kind of regulatory piece that could be a burden. And so we came up with, we kind of started from the ground up and said, okay, what's the ideal expression of what a PDMP could be? So as far as getting, data to the provider, the big thing was to get single sign-on. So now, that we worked with the health systems and with the software designer that we worked with. And so now you can literally click a button while you're in your electronic medical record, and within 5 to 10 seconds, you can have the PDMP data available. The other piece was having the ability to prescriber metrics and really malleability with the software, so you could take a look, and as we move forward, you can see what is going to be most useful for the prescribers, for the pharmacists. For law enforcement, we put in a place for law enforcement alerts to be in for overdose events, and really more like a communication tool. So when you log on, if you can see if one of the patients you prescribed for has overdosed or has had a prescription stolen. I mean, it's really, the thing for me was that every physician would want to know what their patients were taking. There's no reason you wouldn't want to know if they were taking something, but the problem was, what was the cost of that data acquisition? And I was, part of the team, kind of led the team to really make the clinical information useful and easy to access. Mm-hmm. And so that was pretty exciting for me, was to be able to help come up with that.
That's wonderful. That's wonderful. Have you heard back from, do you get feedback from providers in your state about what have been the most significant improvements that you've made to your PDMP? What do other providers, prescribers tell you?
Well, a lot of it is just the easy access to the data. So it's the single sign-on is huge. I think more than like 60% or more of the PDMP data that's accessed is through single sign-on. So it's just really no more clicks, as we, as a healthcare person, having to click and find data can be very time consuming, over time. The other piece is the usability of it. So you can, the form that comes out is very malleable, and we came out with a form that you could, you can click on the data, and you can see immediately whether the patient has any prescriptions, and then if they don't have any, then you can stop. And so but it's ultimately configurable. So there's constantly getting feedback from the docs and from the nurses and from the pharmacists as far as what the shortfalls are, how it could be fixed. And it's this constant process. I always like to say it almost feels like, we started with a rotary dial phone with the PDMP or even less, and then we have an Apple, iPhone 10 now. So you can it's just like boom, boom, boom. And that's the neatest thing, is just the ability to use it. And now I see, people that I talk with that say that they can't imagine not having what we have. And that was the thing, to turn it from a burden that really wasn't that helpful, that took 3 to 5 minutes to access, into something that you really wouldn't, most people wouldn't even consider prescribing without knowing what their patients are taking. And so that was I think that was the biggest improvement, was that shift.
Obviously, when I'm in a really busy clinical setting and I'm seeing a patient, I need the information at my fingertips, and I can't wait minutes. And you're right. I mean, I need to be able to click and find the specific data on that patient that I need in that moment to help me keep moving through my workday. But beyond that, you mentioned something about reports. Are there other ways that providers can access data that allows them to compare how they're doing with others?
Yeah, so when you're as part of the licensing board, you list a subspecialty or a specialty that you're in, and so the Pdmp software actually creates provider metrics reports, so you can see where you fit within the other prescribers in your subspecialty. So it actually, like, one of the top things that comes in whenever you log in or whenever you click in is, would you like to view your prescriber metrics report, and you can see kind of where you fit within your colleagues. And so, and that's constantly being updated as well. It's through the Robert Wood, I think, grant that we got, the federal grants that we got. And so there's this constant process. Instead of just getting lowest bidder software and, checking the box for, okay, here's a Pdmp, now the prescribers have to figure out how to use it. It's like, what could the ultimate expression be, and how do you keep reimagining what that is and then changing that? And so it's pretty cool. That's the biggest piece, I think, is the ability to move forward with a useful tool and to not let it be a burden.
Sure. That's exciting. That's exciting. Do you have anything that you would specifically recommend? I think you mentioned the single sign-in or the single login as being really critical. Are there other recommendations you would have for other states to consider about their Pdmp program based on your experience?
I think I already mentioned what I think were really key, but I think the big thing is just to engage with the medical community, with the health systems, and kind of build it from the ground up. This process all started through an NGA policy academy in 2014 and 2015. And kind of reimagined how, what's the expression, what could it be? And that's, so for, it might be different in a different state, but the big thing is just to really get, as you're building it or as you're improving it, to get continuous feedback from the shareholders in the, in the space that are accessing it.
Well, a nice pat on the back to your fellow panelists from the NGA.
Yeah, it was phenomenal what came out of that policy academy for the state.
Way to go, Lauren. Well, let's turn to Dr. Hancock, and Christine, thank you so much for joining us. I really appreciate your taking time to do this. Can you just briefly describe again your role in your organization, and how do you currently use the Pdmp in that position?
Yes, good morning, everyone. It's so nice to be here and to be talking about this. I'm a family doctor, and I practice close to full spectrum family medicine in northwestern Washington. And I also oversee our MAT or MOUD programs in our organization, as well as looking at chronic pain and opioid prescribing. And so I was thinking about this morning and really thinking that in my relatively short career, I've really seen the full evolution of this whole process. There was the case in my residency where there was a patient and her husband who I prescribed for. She would come in for kidney stones and complain about her horrible flank pain, and she couldn't sleep. And it turned out that she had received opioid prescriptions from over 40 people within our organization, specifically targeting residents and people who are less familiar. And we had no Pdmp at that point when I was in training to look at. So we didn't know anything about this patient until we actually reviewed clinical records, because she had gone under multiple aliases, and it was just a really shocking and kind of eye-opening experience for me. So when I came here to Washington in 2013 and started practicing, we did have a Pdmp that was basically accessed through a process that Tim was describing, where you have to log on. It takes several minutes, and I would use it kind of periodically and often be surprised by the results that I would find there. And then through the 6 buildings blocks, we actually started to build a workflow where we kind of developed delegate access, where our MAs and our nursing staff would pull those Pdmp reports for us proactively, looking at our schedules for the day, as well as for refill requests. And so we basically were able to kind of get some of that information at your fingertips, but at the cost of a lot of time and effort by our nursing staff. Every morning they would spend 10 or 15 minutes just running that Pdmp report for all our patients. And then finally, we actually moved to an Epic-based system a year or so ago, and that has been an incredible improvement for us in terms of that, integrated access to the Pdmp, including non-controlled substances, as I think Lauren was mentioning, that the importance of that for us, monitoring medication adherence and seeing what people actually got. Sometimes patients don't know what they've gotten from the pharmacy. And then I think in the last couple of years, we've also been looking at prescriber reports, both on an individual level, as well as this year, I've been trying to work with our national or state medical association to look at organizational level prescribing reports, and who are the high prescribers and which specialties are they in, and what is their pattern over time, so that we can start to address those prescribing practices from the top down, not just as an individual responding to their own data. So it's been so exciting for me to see the possibility of this type of data, and to see the improvements that I think it's brought for my individual patients as well. So I'm really glad that we're talking about this.
That's great. Dr. Hancock, what have you found to be the most useful information you get out of your Pdmp, you or your nursing staff or clinic staff? What is the most helpful or useful information you get out of your Pdmp?
I think it's really the basics for me when I'm looking at an individual patient. So it's the date that they filled their prescription, who prescribed it, how many tablets did they get, what was the strength of the tablet, and then what pharmacy did they get it from. So it's not really very sophisticated data, but that often really informs my clinical choices when I'm reviewing a request or trying to figure out, whether this person is due for a refill, or is it early, or are they, going to the emergency room to get meds, or are they really in pain and they're trying their best to deal with it, but they ended up, kind of having a moment where they needed to go to the emergency room. So I think that those are the basic things that I see.
I had an aha moment a while back when someone told me, our EHR tells me the prescribed date, but the Pdmp gives me the filled date, the date they filled the prescription. And they've talked about how helpful that was to be able to look back on that when considering a refill request. So what kind of challenges do you think you still struggle with in using the Pdmp, and what could make it better?
Well, I think, not every clinic in our town or our area has that integrated Pdmp access. And I actually just tried, for the sake of argument, to log in today because I haven't done it for a while. And it did take me 3 minutes to get in. I had to reset my password. I couldn't find the right login name. I had it written down in a different file. And so I think for those clinics that don't have the privilege of, having integrated access, we need to develop a better system that is kind of universally accessible and usable.
That's great. That's great. What about thinking about it from, you have a hat not only as a clinician, but as a quality improvement leader in your organization. Are the ways the Pdmp could be made useful within your organization for quality improvement activities?
I'm really fascinated by the kind of comments that Tim had about those immediately accessible reports, because we don't have that built into our software. And I think, the reports that we get come out quarterly, and they're actually backdated by 6 to 18 months, depending on how updated the State Medical Association is. So for me, it's much more kind of applicable to look at real-time data to know how my prescribing is comparing to that of my peers, not what I was doing 18 months ago. So I think that's actually a really great functionality that I'd love to see integrated here locally.
That's great. That's great. Well, why don't we turn to questions from the participants today? I see one in the chat. Michelle Rico Jonas asked, has anyone surveyed prescribers and dispensers? She's looking for sample questions to better engage the medical community about using the Pdmp. Any panelists have thoughts about what kind of questions should we be asking medical providers that would help improve their engagement in using Pdmp?
This is Tim.
Go ahead, Tim.
So we found it very difficult to engage people initially. So, I mean, that's what part of our reform strategy was, to have a requirement that people, look at the Pdmp before they prescribe, a certain amount, more than 3 days worth. And we're actually looking at changing that to all prescriptions for opioids and benzos. once people became used to it and it was the norm and it was easy and useful, now people would be, I've heard people say they would be mad if we didn't, if we got rid of the PDMP, it would be. So it was the big thing was, how do you get that cultural shift? And that was really hard to do that. I mean, we had like 13% on the old system, 13% of PDMP was being used before prescriptions were given. This was in 2014, 2015. And now it's 90 something percent. But I think to get, I don't know if they're not, if you have to have a really useful and easy to use and good quality data. But even that might not be enough to get it started. I mean, I'm not a big, government involvement person into healthcare, but I think this was a necessary step, was to but again, it sunsets. So it sunsets after 5 years. So it goes away. So the requirement doesn't last forever. It's just until the culture gets shifted.
Yeah, changing culture is difficult.
Yeah.
In terms of the culture of how medicine is practiced, but it sounds like the shift has happened in Wisconsin. What do you think the keys were to that culture shift?
Yeah, that was, again, just getting people to see what a useful tool it was and getting them used to using it. And that was the key thing. And again, that was the hardest part, I think. And that's where the backup of the state and the medical board, came in. We promoted guidelines that we, went with the medical board. So they weren't just CDC guidelines, but they were based on the CDC guidelines. And then people started, and this was before people knew that really overprescribing was an issue. This was back in 2015.
Right.
And so, but the whole shift has occurred, and not from a top down, but from the ground up. And that was the key.
Yeah. People talk about tipping point phenomenons in this kind of work, and how there's usually this tipping point where either people are not using it or people say, oh yeah, this is just the way we do it here. This is how we practice medicine in Wisconsin. And people tend to say, okay, well, I'm going to be consistent with the rest of my tribe of professionals here in the state. I'm going to do it the way everyone else is doing it. But that's a hard tipping point to get to. It's a heavy lift. So, but congratulations, that's wonderful. So I'm looking at the time, and I just wanted to